Thank you, Anand. Um, I hope I'm audible, and I'll be speaking on OCT, novel terminologies and biomarkers. Just one second. Right. So, biomarker is essentially a characteristic of.
Can you, Pukhraj, make it PowerPoint slide presentation mode?
Okay. So, is that okay?
Yes, that's good.
Okay. So, I'll be speaking on novel terminologies and biomarkers in OCT. So, some of the terms are often used, and they are uh, because of so basically I'll be using some very basic terminologies and touching on some newer ones. So the biomarkers which are OCT based can either be quantitative or qualitative. The qualitative ones could include those which have a retinal structural alterations like gross alterations, including central subfield thickness or the cube average thickness, and others could be ultrastructural, meaning disruption of external limiting membrane or ellipsoid zone. There could be others which are surrogate endpoints, meaning findings in the choroid, and certain others at the vitreoretinal interface. So it could be a qualitative assessment which could help us prognosticate different conditions. And this slide shows staggered view of those biomarkers at different levels, anatomical levels, namely at the VR interface, within the neurosensory retina, and at the outer retina, at the RPE basement membrane choriocapillaris level, at the choroidal level, at the chorioscleral junction, and then the applications of artificial intelligence and the biomarkers in systemic disease. So the simple ones, we are very familiar with the flying saucer sign. Something similar to that is the perifoveal inner retinal thinning with hydroxychloroquine, and this is a marker of impending maculopathy. So DRIL is very simple, basic. We are familiar with this. It's a disorganized retinal inner layer, and it is to be looked at within the central 1500 microns region of the fovea, and it denotes ischemic changes. It's a very good marker for diabetic macular edema. Here at the arrow, you can make out, particularly which is not very far from the fovea, the inner retinal layers are not very well delineated. Okay, so then comes SANFL. So these terminology might sound like alphabet soup, but they are pretty easy to understand. This is denotes swelling of the arcuate retinal nerve fiber layer, and this happens in patients undergoing macular hole surgery and ILM peeling. The scan on the top shows you the swelling in the nerve fiber layer. The scan below, the structural OCT scan, shows you resolution of the swelling in the arcuate nerve fiber layer. So this can give us a feedback on how our tissue handling has been in cases of ILM peeling. Another associated finding is that of dissociated optic nerve fiber layer. So this sign appears as a dimple, and it is seen as multiple arcuate striae on the inner retinal surface within the area of the peeled ILM. Here you can see on the left this image which shows a demarcated area of ILM peeling and the dimpling on the vitreoretinal surface, vitreoretinal interface, showing adequacy of ILM peeling. So this brush border pattern is very familiar to us handling cases of CSR, but it also is seen in patients who have tumors like choroidal nevus or circumscribed choroidal hemangioma, which can masquerade as central serous retinopathy. This dipping sign, again familiar with the CSR cases, here the outer retina tries to impinge on the RPE because of the fibrin. The pearl necklace sign is a contiguous ring of small hyperreflective dots within the inner lining wall of the cystoid spaces. This denotes chronicity and a poor prognostic outcome. So the optical density ratio, which is associated with intraretinal cystoid spaces, can be analyzed by having a ratio of the optical density of the fluid within the cystoid spaces and comparing it to the optical density of the vitreous body. So this optical density derives its value from the proteinaceous content within the cystoid spaces. And hence, this sign is considered a direct indicator of the integrity of the blood-retinal barrier, because this is very often seen in diabetic macular edema. So coming on to the retinal pigment epithelium, we know that retinal outer RPE, outer retinal atrophy, is RORA, and I stands for incomplete, and C stands for complete RORA or RPE, outer retinal atrophy. So CRORA stands for geographic atrophy, and incomplete RORA is a precursor of geographic atrophy. And here are the scans. Here you can see on the upper scan, on the right hand side OCT, you can see the dipping of the outer plexiform layer, and in the OCT scan on the right panel, in the lower panel, you can see it does not go, the OPL does not go all the way to the RP Brooks membrane complex. So the upper one denotes a complete RORA or a geographic atrophy, and here where the OPL does not reach all the way to the Brooks membrane is incomplete RORA. So those are the two entities we need to know. So quantitatively, it should be more than 250 microns in diameter to be termed as CRORA. So Drusen Ooze. Here, if you follow up these patients of Drusen over a long period of time, OCT is invaluable in understanding the pathophysiology of this condition. So what happens is this deposits under the RP extravasate into the subretinal space, and that induces phagocytosis of this lipoproteinaceous material into the RP. But this process is so overwhelming for the RP cell that it leads to cell death, and that again liberates this intracellular RPE material into the subretinal space. This cascade of events leads to the collapse of drusen and subsequent geographic atrophy. So this is called Drusen Ooze. This is not a part of neovascular AMD, but a process of dry AMD leading to geographic atrophy. So moving on to ectopic inner foveal layers, this is relevant to the epiretinal membrane, and this is seen as a form of a continuous band straddling the foveola. It could be hypo or hyper reflective, and it straddles across the foveal region and involves the inner nuclear and inner plexiform layer. So here in this scan, you can see on the right, the foveal dip is maintained, but there is an epiretinal membrane, and there is very minimal anatomical disruption. In the second OCT, you can see the outer nuclear layer is ectatic and going way up all the way to the epiretinal membrane or the foveal surface, and the foveal dip is lost. In the third stage, you see that the ectopic inner layers are now seen, and that is different from the stage 2. The inner foveal layers are straddling the outer nuclear layer. So because of further traction, and this inner layer also gets ectasia. And in the fourth stage, there is almost a complete anatomical disruption of the macular retinal layers. So here, sometimes we can make out a difference between a combined hematoma of retina and RP from advanced long-standing ERM by the help of an omega sign, and that we'll see later. So the central bouquet anomalies are also related to epiretinal membrane, so we can deal with it here, and it occurs within the central 100 micrometers of the fovea, and it's seen typically with stage 2 ERMs, where the foveal dip is lost, and there are 3 stages to it. And all this action happens in the four outer retinal layers, meaning ELM, EZ, interdigiting zone, and RPE. So first there is the fuzziness of the ellipsoid zone, which is called cotton ball appearance. Then there is a foveolar detachment with a loculated fluid of subfoveal fluid, and then there is an acquired vitelliform stage. And here we see that you can see the foveal dip is lost, and on the right side you can see the ellipsoid zone is becoming fuzzy. In the second OCT scan on the right, you can make out the foveolar detachment, and in the third OCT scan on the right, you can make out the acquired vitelliform lesion, which is hyperreflective, inferior to the interdigiting zone and superior to the RPE. So there is an inherent role of Muller cells which extend from the ILM to the ELM because of the transmitted traction which is involved by the Muller cells in the pathophysiology of this disease entity. And here it is seen a correlation between the schema of things superiorly, how the orange colored Muller cells exert traction on the outer 4 layers and how the disease progresses. So the loss of parallelism is a common a colloquial phrase that we hear in the clinic, and this denotes how parallel the line objects are to each other on OCT, and this can actually be measured. So here you can see on the right top scan, this box is an area of interest, and in the B, it's magnified. In C, it is the noise reduction is done, and in the D, this is binarization, and E denotes skeletonization. So a value can be put to this, and the parallelism calculated for this area is 0.937. So it can be used for follow-up cases also. So omega sign, as we saw, this is the omega sign on the scan here. The outer retinal layers are quite preserved. We saw that in ERM, this can be disrupted. But here, because it's a case of combined hematoma, the outer retinal layers are preserved along with the acute disruption of the inner layers and the omega sign. So coming back to macular hole surgery, macular hole surgery can cause persistent outer retinal defects or outer foveal defects. And there is also something called microcystic maculopathy. These are optically empty spaces which are more or less square shaped, but at least one border should appear concave. Here on the left scan, you can see there is straightening of the border of this microcystic lesion in the inner nuclear layer. So the ELM bulge, this is a normal anatomy, and happens because there's a centrifugal migration of the inner retinal layers away from the fovea with the centripetal migration of the cone photoreceptors. So preservation of foveal bulge after any kind of retinal surgery helps in denoting or prognosticating a good visual outcome. So there was an interesting study on PFTs, and that is about the epiretinal neovascularization. So because this study was from India, I wanted to include it. And here you can see even on OCTA in D2, you can clearly make out this is an epiretinal neovascularization, and this is certainly added to our understanding of this disease. So PAM is a new variant of acute macular neuroretinopathy. So it is now classified into type 1 and type 2. Here, as we can see, the type 1 is more superficial or in the inner retina. The type 2 is in the outer retina. So here you can see there is atrophy of the inner nuclear layer in the type 1, and there is atrophy of outer nuclear layer in type 2. Here are 2 cases which we managed. Here you can see with the arrow, there is a fuzziness of the outer plexiform layer and a corresponding dip in the convexity of the nerve fiber layer immediately atop it. So this was the deep capillary plexus also showing some deficits in the panel B here. So this was more or less a long-standing case, but we saw another acute case. Here you can see the fuzziness of the outer plexiform layer and corresponding changes in the OCTA here. In this panel E, you can make out, this is right at the inner plexiform layer. So ORCC splitting, and there are certain other entities which should not be confused with subretinal fluid and be subjected to unnecessary treatment. So it's important to recognize this. This happens with Best's vitelliform macular dystrophy, where there is splitting at the level of RPE and Brooks membrane with collection and accumulation of this vitelliform material. So choroidal vascularity index is an established entity. I'm sure Jay will cover this, and it involves quantification of choroidal vascularity, the measuring the ratio of lumen area to total choroidal area. And the simple way to remember is it's about two-third value. It comes to about 66% in normals, and it can be used as a biomarker for CSR, pachychoroid spectrum, and also diabetic retinopathy. Here in a study from our group, here you can see the CVI is decreasing with increasing severity of diabetic retinopathy, going down from 67% to 61%. There is another sign which is described by Dr. Giridhar and his group, and there is a lateral elongation of flat irregular PED. So in this article, I also saw, I could literally sense that it is an expanding PED, but the lateral elongation is a little bit better pronounced. And they also saw in the study that it is a precursor lesion for PCV in the fellow eyes. So this could be an important sign for us to follow. And here you can see there is fluid above this irregular PED, and eventually there will be PCV lesions at the edge, this abrupt elevation of RP, this polypoidal lesions at the lateral edge of the PED. So this is a good way to follow up such cases. Choroidal macrovessel could be a differential for a choroidal hemangioma or subretinal parasite, retinochoroidal anastomosis, or a vortex vein varix. So here you can see an example. And the color fundus photo, there is a curvilinear lesion which is running across the fundus, and here you can see corresponding images of the OCT. Another case which I saw in the clinic is a large fibrovascular PD on the left, you can see, and on the right on the ICGA you can make out a very prominent feeder choroidal vessel. So dome-shaped maculopathy, dome-shaped macula is best detected with a vertical scan because they are most likely oriented horizontally. So you may miss if you're running a horizontal line scan in such an eye. Last few slides. So this could be associated with fluid or CNVM. And then there are biomarkers of AMD, where it is important to distinguish between degenerative intraretinal cysts, which will not benefit from treatment, to those which are exudative, which will benefit from treatment. So it can also help us to quantify the macular island in peripheral retinal diseases like choroideremia or Usher's disease or other retinal degenerations. And also choroidal thicknesses are found to be reduced in Alzheimer's, and this can be followed up. There is a way to know the choroidal vessel layer analysis, like quantifying Haller's and Sattler's layer. And there are several choroidal biomarkers associated with geographic atrophy in particular, namely choroidal caverns, choroidal round hyporeflective findings, choroidal hyperreflective foci. Here you can see there is a geographic atrophy, and the RP migrates into the choroid and is shown as hyperreflective dot echoes. So there are also hyperreflective pyramidal structures. Its importance is not very well understood, but they are known to be non-progressive and occur in the areas of geographic atrophy. So intrachoroidal cavitation is associated with the myopia, and it is at the inferior border of the myopic conus. So there are several algorithms to detect diabetic retinopathy, ROP, and AMD with artificial intelligence, and also detect their progression, as Dr. Muna has covered in her talk. Reticular drusen are located above the level of the RP, while the red arrowheads show drusen which are below the RP. So likewise, pachydrusen is associated associated with PCV and pachychoroid spectrum.
Pukhraj, can I ask you to conclude your presentation?
Yeah,
if,
just last
if you have a few slides.
Yeah, just the last few slides. So outer retinal tubulations and outer retinal corrugations should be differentiated from subretinal fluid. There are Drusen substructures, but I'll not go into that, and wedge-shaped subretinal hyporeflectivity. So these three things should be differentiated from subretinal fluid to prevent overtreatment. So we know about SHREM, and laminar hole associated epiretinal proliferation is important to know because the epiretinal membrane in this goes deep into the retina and should be careful while peeling this. So again, multi-layered PED, again associated with AMD, and this is a juxtapapillary choroidal excavation with PCV. Choroidal knuckle should be differentiated from a hotspot as seen in this report. And in conclusion, biomarkers are helpful in prognostication, but clinical correlation is essential. Thank you for your patient hearing.